having us.
For our next speaker, we're going to have Dr. Nadine Palermo. Dr. Palermo is an instructor in medicine at HMS. She's also Associate Director of the Acute Diabetes Care Program at Brigham and Women's Hospital. And we are grateful that she's here today to discuss evidence-based approaches to inpatient hyperglycemia. Dr. Palermo, thank you so much for joining us.
Thank you so much for that kind introduction and invitation to be here. I hope everyone is enjoying the conference. And it's my pleasure to give some insight on inpatient hyperglycemia, a topic near and dear to my heart, and I know quite common to many in the audience today. So here are my disclosures. And I thought I'd get us started off with the case. This is a 55-year-old gentleman with hypertension, hyperlipidemia, who's coming in with chest pain and admitted for an NSTEMI. He has no prior history of impaired fasting glucose or impaired glucose intolerance, but the serum glucose on admission is 220 milligrams per deciliter, and the fasting the subsequent day is elevated at 200. So my first question for you is this important, and what is the role for monitoring and treating? What I'm going to cover for our time together today is really to briefly go through the rationale for glycemic control in the hospital, to discuss some evidence-based recommendations for glycemic targets, talk about some management strategies for some common inpatient clinical scenarios, and lastly, to review some of the new therapies that we have for diabetes, including new non-insulin agents and technology, and how this has an implication for us in the acute care setting, as well as transition of care. So I would be remiss if I didn't first say that the prevalence of diabetes continues to rise. Every time I talk about this, the numbers continue to go up, but we are now exceeding over 30 million in the United States, which is predicted to triple almost worldwide, affecting one in three adults. And then worldwide, we're seeing similar estimates, right, for a projected rise of over 783 million. This accounts for over 14 million ED visits, 7 million hospital discharges. So in addition to the prevalence that we're seeing, this is also really expensive for the healthcare system. And when we think about these patients, it's really important to think about who are we talking about, right? So patients in the hospital with hyperglycemia really represent three patient populations: those with established diabetes, those with diabetes that was previously undiagnosed and picked up during the inpatient admission, and then finally, those with stress hyperglycemia, or those who have normal glucose tolerance prior to their presentation, but in the setting of acute illness have hyperglycemia. And the reason I also highlight this third group of patients is that we know that even stress hyperglycemia actually does pose a lot of harms and is associated with adverse sequelae. So this can happen in the setting of acute illness related to insulin resistance. It can happen from a number of our therapeutic interventions, steroids, dextrose-containing fluids. But what we do know is that hyperglycemia can actually pose, again, adverse effects with impaired wound healing, increased risk of infection, and so on. So it is important to also pay attention to this group of patients. This has actually been studied. So looking at hyperglycemia in hospitalized patients, this was one study looking at med-surg patients, and just of note, about a quarter of these patients had a known history of diabetes. And what I'll highlight are those that were picked up during the acute hospitalization with either new hyperglycemia or stress hyperglycemia actually had worse outcomes. So some would argue that this group is equally as important to pay attention to because it may be a marker of severity of illness. So why is this relevant to us? Inpatient dysglycemia is exceedingly common in patients with and without established diabetes. It can increase our risk of hospital complications, increase healthcare utilization, and is associated with a higher in-hospital mortality. And as I highlighted that group of stress hyperglycemia, some would argue that this is actually a marker of severity of illness. But most importantly, and why we're here today, is that appropriate glycemic control can really reduce all of these risks. So I'm going to take us on a little bit of a whirlwind tour because it's always important to know what we've learned and what has governed really our practice. What I've included for our talk today are some of the key studies that have really informed our guidelines and our management strategies. I'm going to give you the high level version and include some reference so that you can take a look if you'd like some additional detail. But really the story began in 2001 with this prospective randomized control trial in a SICU in Belgium. And this was the first time that we really looked at the role of intense insulin treatment and and intense glycemic control. And what they found in this patient population that this was associated with a number of improved outcomes. So you can imagine that everyone got really excited about this concept of tight glycemic control and started looking at this in various different patient populations, so surgical patients, medical patients, and really tried to keep pushing the glucose lower and lower. And what I'll tell you, just big picture to know, is that there's a lot of great evidence, particularly in some patient populations, the perioperative patients, cardiac surgery, with a clear indication and role for tight glycemic control. But then as we push tight and tighter, look fast forward to 2009 with this multi-center international randomized control trial in a mixed MICU-SICU patient populations, pushing not just tight, but also for near normal glycemia. Turned out that actually does not benefit all patients, right? So you do have to really select your patient population and find that sweet spot, because it turns out that tight glycemic control, while it's a benefit for some patient populations, is not in fact true for all. And hypoglycemia, particularly in-hospital hypoglycemia, is also associated with poor outcomes. It can increase, it's been associated with increased risk of death in the subsequent year, longer length of stay, as well as a number of complications. So what have we learned all these years? That there are certain patient populations who are at an increased risk for hypoglycemia. Older patients, patients with impaired renal function, changing nutritional intake, any changes or interruption in glucose monitoring. Those are the patients that we have to pay attention to. And there certainly are some that are at increased risk of hypoglycemia. So what do I want you to know from the decades of evidence that we have is that there is a benefit of tight glycemic control in some patients. Some populations are more prone to hypoglycemia. Treatment is important to prevent the sequelae of hyperglycemia, but it's about individualizing your targets and your treatment to the patient to really find that sweet spot. So what are the recommendations? So for all those patients who are admitted to the hospital, recommendations are to get a glucose on admission. For glucose is over 140 or a history of diabetes, the recommendations are to actually monitor glucose levels with point of care testing. Depending on if a patient is eating or NPO, you can think about doing this with meals and bedtime. The recommendations officially say to do this within pre-meal testing within an hour of the meal. And for those who are not eating or on enteral nutrition, to use every 4 to 6 hours. For patients who are hyperglycemic, recommendations are to check the hemoglobin A1C if it hasn't been assessed in the preceding 2 to 3 months. Again, really getting at the concept of trying to make sure we're not missing new hyperglycemia. One quick word is that don't forget caveats to hemoglobin A1C. Anything that's going to alter your red blood cell turnover is going to affect the hemoglobin A1C, so it should be interpreted in that sense. So what are our targets? What I've summarized here is that you'll see there's a number of organizations looking at the critically ill patient population and non-critically ill patient population. And what you'll notice, so we have the American Diabetes Association, Endocrine Society, Critical Care Society, various surgical societies. What you'll see here is that some of the surgical societies are targeting lower glucose levels. This is because of the evidence that I mentioned briefly earlier, is that there is pretty significant literature supporting tighter glycemic control in the surgical patients as compared to maybe other patient populations. But we will try to keep it simple, and we'll focus on the critically ill patient population and targeting glucose of less than 180. And in non-critically ill, pre-meal glucose less than 140 and a random glucose less than 180. My caveat to this is, like everything else in diabetes, you really should individualize your treatment and your targets based on the patient. So one of the things that is really important is that higher glucose levels, maybe less than 200 as opposed to less than 180, might be appropriate for some patients, particularly those who are at the highest risk of hypoglycemia. So why are things different in the hospital, right? Patients are eating differently, their activities is different, their medications are different. Some of our therapeutic interventions may lend itself to hyperglycemia. Their eating patterns are different. They're sick. We have that illness-related insulin resistance, may have fluctuating renal function. And then last and certainly not least, you can't forget about their underlying diabetes phenotype. So the first question that usually comes up is, for patients who have established diabetes, can I just continue their outpatient program when they're in the hospital? So what I've summarized here are some of the major classes of diabetes medications. And as we think about it, let's take a step back to think about the advantages with respect to glycemic control and the disadvantages that might be appropriate to consider in hospitalized patients. So the first is metformin. So good news is metformin has a low risk of hypoglycemia. But the reason that metformin is typically not necessarily continued on admission is because of potential changes in renal function. Metformin-associated lactic acidosis can be rare, but you do need to think about it, particularly in patients at risk for hypoperfusion. Some patients are often getting imaging studies with contrast. So for that reason, metformin is typically not continued on admission. I'm going to come back to metformin later for scenarios for which you may restart it as part of your transition of care planning. But for right now, I'll say much of the data will support not necessarily continuing it on admission for that reason. Sulfonylureas, the greatest risk here is really going to be hypoglycemia. If you think about the mechanism of action, it's going to force the beta cell to squeeze out insulin. So that can be a little bit complicating for patients who may not be eating as regularly or have changes in, let's say, renal function. So same thing for that reason, typically sulfonylureas are not necessarily continued on admission. So TZDs are thiolidosone-diones, also low risk of hypoglycemia, but the real disadvantage and the reason you have to be careful here is going to be fluid retention. So there are some patient populations for which this may not be appropriate outpatient, and that is equally true, of course, in the hospital. So the last three categories, the DPP-4 inhibitors, GLP-1 receptor agonists, and SGLT2 inhibitors are probably our newest medication classes. I'll start with the first two, the incretin mimetics, the DPP-4 inhibitors and GLP-1 receptor agonists. Good news here is that low risk of hypoglycemia and with both of these agents. And for this reason, they've been a really attractive agent to think about in hospitalized patients. And I'll share some data in just a little bit. So for that reason, you actually have, you are starting to see more and more use in the hospital. There really aren't any contraindications from a glycemic perspective to DPP-4 inhibitors. I will say with respect to GLP-1 receptor agonists, sometimes the challenges can be surrounding patients' planned procedures. So for patients who are on these agents in the outpatient setting, there are different recommendations based on the agent and potentially holding prior to a planned procedure. So for that reason, we typically do not necessarily also continue those on admission. SGLT2 inhibitors, also low risk of hypoglycemia. There is limited data from a glycemic perspective in the hospital, and in the real sort of concern and challenge in the acute care patient population is the risk of euglycemic TKA. So this is also rare, but the patients for which we do see this in tend to be sick with fluctuating volume status, insulin deficient patients. Same thing is true that we have guidance depending on which agent the patient is on prior to any planned procedures. So for this reason, from a glucose perspective, these agents are typically not necessarily considered. I will just make a quick caveat that, of course, there is a role for these agents for other medical indications. And, you know, in some of our cardiology talks that you'll have as part of this conference, you'll hear about the role of SGLT2 inhibitors. But from a glucose perspective, not necessarily one that we would continue on admission. So for this reason, insulin has really been the mainstay of treatment for hyperglycemia in hospitalized patients. And this can be a little daunting. I recognize that. So half the battle is really knowing what's in your armamentarium and how you might use insulin most effectively. So what you'll see here summarized are some of the pharmacokinetic data by rapid-acting insulin, short-acting insulin, intermediate, long, and premixed insulin. And what you'll notice here is, what I want you to remember is insulin. It just matters when it starts working, if and when it peaks, and how long it lasts. And if you can remember that, you can do anything with insulin. For those who are a bit visual, again, thinking about the pharmacologic activity, just remember insulin, when it starts working, if and when it peaks, and how long it lasts. So if you can think about what we're actually trying to do with insulin, designing a regimen can actually be quite simple. We're basically trying to mimic normal physiology. So what happens? Everybody has this baseline amount of insulin that's secreted from the pancreas to keep the glucose at goal in between meals and overnight. There's our flat line over here. When you eat, glucose rises, right? The pancreas senses the rise, secretes insulin in response, and lowers the glucose. So here's our breakfast, lunch, and dinner. So if you think about designing a regimen, we are basically just trying to mimic normal physiology. And when you're thinking about actually writing insulin orders and determining what dose, you can think about it in those sort of three simple ways. You can think about a basal insulin, a prandial insulin, and a correctional insulin. So insulin is the recommended agent for glycemic control in hospitalized patients, but you can give this actually a few different ways. You can give it IV, you can give it by correction or sliding scale only, you can give it as a basal bolus regimen or basal only. So let's start with IV. That's perhaps the first. So when to consider IV insulin? If you think about IV insulin, the onset is very fast. So it's easy on, easy off. So the real indications for IV insulin is going to be in the setting of hyperglycemic crisis, labor, critical illness. It's very routinely used after cardiac surgery, post-transplant in the critical ill patient population. And it's because of the flexibility with the short half-life. What about subcutaneous insulin? So there are a few ways that we can do this. We can do this with a basal bolus regimen. We can do this with a basal only program, a correctional only program, or a basal and a correctional. And how might you think about that? So another study just to be aware of, this is also really one of the key studies that have governed our practice. It's the RABBIT-2 trial. And this looked at the concept of the idea of basal bolus versus sliding scale only. And in this multi-center prospective randomized controlled trial in non-critically ill patients, what you'll notice here is that basal bolus is a safe and effective means to achieve glycemic control. And this study was also done in surgical patients, and we saw similar outcomes. So for this reason, this is really one of the foundational studies that governs our practice and how we think about insulin. So good news, insulin is a weight-based medication, and most would argue that you think about 0.6 or 0.3 to 0.6 units per kilo per day, maybe a little bit less for those who are at risk for hypoglycemia or insulin naive. But when you think about it, and we'll sort of talk through how we might come up with dosing, I want you to remember two things, thinking about the patient's home program for those who are on insulin therapy versus this weight-based approach. So how do I think about it? So for patients with known diabetes, I think the first thing that I think about is what was their control? Is this a patient who's coming in with an A1C of 6.8, or is this someone who's coming in with an A1C of 13? Right? It might be different when we think about their compliance or other factors that might contribute to their overall diabetes control. One of the very common things that we see is that patients in the ambulatory setting are on once-a-day long-acting insulin. For these patients, it's actually really important to take a look at that dose because perhaps that long-acting dose is covering a bit of their basal and their prandial requirements. And then as soon as you have someone in the hospital who may not be eating as they do at home, all of a sudden that dose might actually be too much. So that's really important to think about when you're evaluating what dose of insulin to give. And then lastly, risk factors for hypoglycemia that we talked about a little bit earlier, particularly changes in renal function, older patients, and hepatic and pancreatic dysfunction. So this is a simple strategy, which I like to use to sort of think about coming up with a weight-based estimate. So if we say most patients need about 0.5 units per kilo per day, what you'll see here is that I will recommend adjusting by factors that would either increase the risk of hypoglycemia or insulin resistance to help you determine this starting of just a place to start, and then we'll talk about titrating in just a moment. So what you'll see summarized here are either increasing or decreasing by about 0.1 units per kilo per day to come up with a total daily dose estimate. And we'll go through some examples in just a few moments. So you have your total daily dose estimate. Most often, if you think about those three components that I shared, we're going to divide this as your basal, your nutritional, and your correctional. Most often, you're thinking about 50% as basal, 50% as nutritional. However, there are some clinical scenarios for which you might sort of skew that ratio and do a little bit less basal, a little more nutritional, or depending on your patient. But we have our basal, we have our nutritional, and then lastly, we have the correctional piece. So the correctional insulin, what is this? This is the predictive effect 1 unit of insulin will have on glucose. Some may have heard of this as the rule of 1500 or the rule of 1800. So basically, you're taking 1500 divided by your total daily dose. And this is going to ballpark your correction factor or your sensitivity factor. So what do I mean by this? For every 1 unit of insulin I give, you will move the glucose by X milligrams per deciliter. So for example, for someone whose total daily dose is 50 units, 1,500 divided by 50 is 30. So for every 1 unit of insulin, you would expect to lower the glucose milligrams per deciliter. This is our sliding scale. So if you think about doing the math, and for many who are using insulin orders, whether it's electronic orders in the hospital, this is your low, moderate, or high dose correction scale. So if you were to do the math with a total daily dose of less than 40 units a day, that would equate to about a 1 to 50. So 150 to 201 units, 200 to 252 units, and so on. If you did the math for a total daily dose of 40 to 80, that would be your 2 to 50 or your 1 to 25 correction. So that's your 150 to 202 units, 200 to 254 units, and so on. And then for anything over 81 units, that's where you're really going to go in to calculate a high dose or a custom scale based on the math that I just shared. So let's do an example. So we have a 60 kilogram patient with normal renal function. And if we're going to go through some of the steps to get that total daily dose and how we might design the regimen, 60 times 0.5 is 30 units. So 30 units is your total daily dose. If you're going to take 50% of that as your basal and 50% of that as your prandial, you have 15 units of basal, 15 units of prandial. For those who are eating 3 meals a day, that's 5 units with breakfast, 5 with lunch, 5 with dinner. And then if you go on to do the correction, 1,500 divided by 30 is 50. So this is your 1 to 50 scale, or for every 1 unit of insulin, you'd expect to decrease it by about 50 milligrams per deciliter. So we have our calculation, we have our targets. How do we get there? So much of what I'm going to share now is also based again on those rabbit trials that I showed earlier. So you're really going to look at the data that you have and adjust accordingly. So if the fasting is above goal, you're going to think about the basal to adjust. If the pre-lunch is above goal, thinking about adjusting the breakfast bolus. If the pre-dinner is above goal, the lunch bolus. And if the bedtime is above goal, adjust the dinner bolus. And really utilizing increases or decreases by about 10 to 20%, depending how far off you are from your target, is a good strategy to think about for making adjustments. So for example, if the fasting glucose is 250, you can think about adjusting the basal insulin by about 20%. So what kind of scenarios do we come across in the hospital? There are many to consider. What I've summarized here are some of the more common to think about as a framework for how you might design your regimen. So for patients who are NPO, that's perhaps the easiest, right? So if they have a basal requirement, you can use long or intermediate acting insulin for their basal and use maybe regular insulin every 6 hours as your correction scale. Next category, for those who have unreliable PO intake. So same principle is true if the patient has a basal requirement, you're using long or intermediate acting insulin. You can consider rapid acting insulin either with a dose reduction for decreased PO intake, or one strategy is perhaps just a correction scale only for those patients until you have established adequate and reliable PO intake. For the patient with reliable PO intake, this is your traditional basal bolus program, the example that we just went through. Basal insulin, giving rapid acting insulin with meals, and with it as a correction scale as well as a nutritional dose. So what about parenteral nutrition? So same thing, if they have a basal requirement, you're thinking about that separately. But for the nutritional component, one of the best and safest strategies is actually to add the insulin directly to the TPN bag. And this is a nice safety because if the patient is receiving the TPN, they will receive the insulin. If they're not receiving the TPN, they don't receive the insulin. So you decrease the risk of hypoglycemia. What about enteral nutrition? So this really does depend on your actual regimen, right? So for, let's say, continuous tube feeds, you can take that nutritional insulin, divide it by 4, give it as regular insulin every 6 hours. For patients who are on cycled tube feeds, let's say a 12-hour cycle, you can consider giving NPH at the onset. You can give regular at the onset and halfway between. You can use a Lispro or Aspart. You can also use that. You can really do any increment you want as part of the nutritional cycle, as long as you're timing it when the nutrition is given. And similarly, for a bolus tube feed, you can think about that as giving rapid acting insulin, almost like a meal bolus. One of the safeties here to pay attention to is that you're really clear that this is only to be given if the patient is receiving the tube feed, because sometimes that can set you up for insulin to carb mismatch. So utilizing order sets that have additional safeties built in, it's a nice strategy. And then lastly, what about steroids? Very common in the hospital. Same principles with basal insulin. We're going to go through some examples specifically about steroids, but one of the things that is often considered is using an NPH-based program or escalating doses of rapid-acting insulin to address some of the hyperglycemia, excuse me, that you expect after steroids. And I'll come back to that in just a little bit. So let's take a look at our first patient. The 65-year-old gentleman with a long-standing history of type 2 diabetes who's coming in for a GI bleed and who's NPO. Is an outpatient, takes Glargine 80 units daily, Lispro 20 units with meals, metformin a gram twice a day, sitagliptin 100 milligrams daily. He's 120 kilos. On admission, his creatinine is 1.6, up from baseline of 1, and his hemoglobin A1C is 10.2. Tells you he's always compliant with the oral agents, but sometimes forgets his insulin. So when you're thinking about a program for him, how might we start with dosing, right? So if we're starting at 0.5 units per kilo per day, he's not over 70, but does have some renal insufficiency. So instead of 0.5, now we're down to 0.4. No known hepatic or pancreatic deficiency, so we're still at 0.4. But his A1C is over 10, so I'm going to give him back a point. So now I'm back up to 0.5. He's not on steroids. So we have our total daily dose estimate of 0.5 units per kilo per day. And if we're going to go ahead to do the math, 120 times 0.5 is 60. So if you were going to do 50% of that as basal, there's your 30 units. 50% of that as prandial, there's your 30 units, but he's not eating, so you're not giving the nutritional component. Then you're going to do your calculation for the correction. 1,500 divided by 60 is 25. So for every 1 unit of insulin, you'd expect to decrease by about 25 milligrams per deciliter. So what happened to this gentleman? He was started on 30 units, and his fasting the next day is 225. He's still NPO. What should you do next? Should you A, increase the basal by 20%, B, continue the current insulin, or C, decrease the basal by 10% because he's still NPO? Thank you so much for your participation. I see about 70% on now 80 would like to do A, to increase your basal, and that is exactly correct, right? So the fasting is above your target. So you're going to think about adjusting that dose by about 20%. Terrific. So over the subsequent days, the Glargine was up titrated and he's now at 44 units, but the fasting is 120. And now you're going to advance to diet. I'll just make one quick note that remember, this gentleman had a basal dose at home of 80 units. So on half of that, right, 44 units, his fasting is at target. So this is exactly that scenario that some of that long-acting insulin was actually covering some of his prandial requirements. So always important to do a double check. So he's going to eat now. What would you do? Would you continue the current regimen? Would you increase your basal by 20%, increase the basal by 10%, or continue the current basal and correctional insulin and then start prandial? Fantastic. I think the majority of the votes are to start prandial, which is correct. And when you go ahead and think about to do the math for him, this is that scenario where if you're looking at the dosing and you're using your 44 units as the dose, you might think about, if you did the calculation, it could be about 15 units with meals. But if you're worried that he may not eat what you suspect, you can always reduce the dose. You can, instead of 15, give 8, give 10, just to make sure that the patient is eating reliable. It's a perfectly normal strategy. I think the most important thing to note here is that as his diet advances and as the PO intake picks up, you're probably going to have to adjust the insulin accordingly. And this is another opportunity to just sort of talk, because the question always comes up is that what is the role for a carbohydrate consistent diet in the hospital when we know that patients are not eating like this at home? It's truly for safety of insulin dosing. So the reason for carb consistent diets in the acute care setting is just so you can dose your insulin appropriately. So a patient is not eating 50 grams at one meal, 75 at another, and 30 at another when you're giving a standing dose of insulin. Perfect. So next case, 57-year-old female with type 2 diabetes and COPD who's coming in for shortness of breath. As an outpatient, she's on metformin and sitagliptin. She is 66 kilos, has normal renal function, and her hemoglobin A1C is 7.2%. But coming in for a COPD exacerbation, she's given steroids, and now her glucose is 300. So what should you do next? Should you A, continue the home regimen, B, start sliding scale, or C, start basal bolus? Okay. A lot of great. Everybody is fast. Thank you. A lot of votes for start basal bolus, which is correct. So how might you think about this patient? So as promised, let's talk through how you might design a regimen with steroids. So what you'll see here are some insulin and glucose data, and this is following an injection of steroids. So what you'll notice, you see this more pronounced postprandial rise, which is very classic in patients who are receiving steroids. It's almost, this particular case is going to highlight that increase right over here in glucose, especially midday, throughout the day, and could be more pronounced postprandial. So for this reason, I had mentioned earlier about sort of anecdotally, many experts have used NPH. If you look at the curve of this light blue line NPH here, it beautifully approximates the rise that you see for steroids. So for that reason, some have used NPH as the basal. Some have tried regimens to use NPH quote on top of the regimen. So you have your traditional basal bolus and you're adding a dose of NPH to be given only with the steroids. And this is, again, it's truly a topic of ongoing interest. And into the most recent Endocrine Society inpatient guidelines actually took a deep dive in the literature to see if the NPH-based programs or basal bolus programs where basal bolus were superior. And the truth is that you can actually use both. I think the most important thing that I will say is just anticipate the rise in glucose. So whether you're using NPH or a basal bolus, you should just try to combat the glucose rise with the insulin that you have. The Joint British Diabetes Society also put forth a consensus statement to think about other ways to sort of remedy the hyperglycemia that you see from steroids. And you'll notice the same sort of trend with giving insulin to match the anticipated rise in glucose. So let's go back to our patient. So if we're starting with 0.5 units per kilo per day and adjusting by our factors, she's not over 70. She has no known renal insufficiency, so we're still at 0.5. No known hepatic or pancreatic deficiency. Her A1C is not over 10, so we're still at 0.5, but she is getting steroids. So now we're going to give her 0.1. So now our total daily dose estimate is 0.6 units per kilo per day. So when you're thinking about the sort of strategy and dosing, you certainly can use a 50% basal, 50% prandial, but this is one of the scenarios where you actually might want to consider a bit more prandial because of that rise that you expect from the steroids. So for example, 66 kilos times 0.6 is 40 units. Half of that would be 20 units of basal. If you were going to use an NPH-based program, you can certainly divide that into two doses of 10 in the morning, 10 in the evening. You can give a little more. You can give 13 in the morning, 7 in the evening, 14, 6. You can kind of skew your ratios a bit. Another strategy for the prandial component is you certainly can do 6 units with every meal. You may see some experts also give escalating doses of that rapid acting insulin, 4 with breakfast, 5 with lunch, 6 with dinner, to try to catch that rise in glucose that we expect following steroids. And finally, for her, if you were going to do the math for her correction, you would come out to be about a 1 to 40 correction based on her requirements. The most important thing here is that you should anticipate as the steroids are tapered, you do have to back off on the insulin. So knowing what steroids you're giving and what insulin you're giving is going to be really important. So next case, 32-year-old gentleman with no known past history who's coming in with fatigue and lethargy. Here are his labs. Some of the things that I think you will see glaring will be the glucose of 1487. And what my first question for you is that what is the most appropriate next step in management? Would you start insulin sliding scale? Would you start a basal bolus regimen, transfer to the unit for insulin infusion, or start subcutaneous insulin every 2 hours? But it is very fast. I have a lot of votes for transfer to the unit for insulin infusion. Perfect. So what are we thinking about here? Obviously, the glucose of 1487 is going to lend you down. Make sure we don't miss hyperglycemic crisis. And what I want you to remember is that every time you see this, certainly we're thinking about DKA, but we also should be thinking about HHS, right? So what are the criteria? So when you think about DKA, it's simple, right? There's a D, there's a K, and there's an A. D for diabetes, the glucose over 250. K is the ketonemia or ketonuria, and the A is the acidosis, so pH of less than 7.3 or a bicarb of less than 18. My caveat to this there are sort of a couple scenarios to think about. There are some clinical scenarios for which you might see glucose levels lower than 250. That can represent DKA, so pregnancy, SGLT2 inhibitors. You can see more of a euglycemic DKA, so lower than 250. And then the other caveat is that you really have to make sure when you're thinking about that bicarb deficit to know what the patient's baseline bicarb is. So for patients who have a higher baseline bicarb, you actually may see a deficit at that higher level than 18. So we have our D, we have our K, we have our A for DKA. What about HHS? So the glucoses are often higher, over 600. pH is often a little bit higher, usually see the bicarb a little bit higher, but you may or may not see ketones. But the real clincher for an HHS diagnosis is going to be the serum effective osms over 320. And for this calculation, you're using 2 times the sodium plus the blood glucose over 18. And the sodium for this calculation is going to be the sodium that's reported, not the sodium corrected for glucose. And if you have over 320, there's your diagnosis of HHS. So why does this happen, right? So in the setting of insulin deficiency, think about the physiology, because if you think about the physiology, you can think about the treatment quite easily. So what happens? You can't use your glucose effectively. More glucose is produced. You have hyperglycemia. You have osmotic diuresis. You're losing water. It's setting yourself up, setting the patient up for significant dehydration, which is actually going to cause a counter-regulatory response to a number of other hormones, glucagon, cortisol, catecholamines, growth hormone, which is going to further sort of rev the cycle of hyperglycemia. So over here, we have a lot of hyperglycemia. And when you're not using, and on the other side, you have increased lipolysis and ketogenesis. So you can't use your ketone bodies effectively. You overwhelm the TCA cycle, and then bam, there you have your ketoacidosis. So if you think about the underlying pathophysiology, the treatment is actually just breaking that cycle, right? Fluids, electrolytes, and insulin. You're giving insulin up here, replacing the dehydration, and you're going to fix the electrolytes. So how we do that very quickly, we'll start with fluids. So the first step is always going to be to restore perfusion. This can be done with normal saline or LR. This is just a little snippet from our hospital guideline, but you're really trying to restore perfusion as the first step. And then the subsequent selection of fluids are going to depend on the sodium and the glucose. The other thing I'll just make a quick note about, and we'll talk about electrolytes in just a moment, is that don't forget in the cases where you do see euglycemic DKA and the glucose is less than 250, you're going to have to add back a little dextrose to your fluids a bit earlier, basically to support the insulin until you've restored the metabolic treatments. When you think about electrolytes, this one is really important. When you're treating DKA, you expect potassium to shift. So knowing what your potassium is in the beginning is going to be of utmost importance, because you have to make sure you can safely give insulin therapy. So if your potassium is less than 3.3 before you start your treatment, you actually have to replace the potassium ahead of time because you know it's going to shift. And then also really important to keep monitoring your potassium because you expected it to shift, especially as your acidemia is resolving. This is just an example of our guideline here for potassium repletion. What I'll also just make a quick note, because one question comes up often about bicarb. The role of bicarbonate is actually controversial. There are no prospective randomized controlled trials, and often this is not considered unless there is severe acidemia, so pHs of less than 6.9 that are refractory to other treatments, because most of the studies have not shown any significant impact on the time to resolution for DKA unless you meet this criteria. And then lastly, our third sort of tenet is insulin. So remember, if your potassium is at your target, you can start to give insulin. For years, the gold standard had been an insulin infusion at 0.1 units per kilo, followed by 0.1 units per kilo per hour. Again, just an example from our guideline. And this is still a very common strategy when we're thinking about treatment for DKA. But what I want to share is that you can think about your patient and really stratify based on the severity of DKA. And there are alternative strategies that you might want to utilize for hospitalized patients, particularly with a subcutaneous insulin approach. So if you think about, here's just a little summary of classification of patients. So we have mild, moderate, and severe DKA and HHS. You'll notice that this is stratified based on pH and bicarb to really help to understand where it might be appropriate to treat your patient. For mild or moderate uncomplicated DKA, you might consider a subcutaneous approach, and there is some literature on that. Really, for severe DKA, HHS, or DKA, HHS overlap, those patients are probably going to be best served in the unit because they do need more intense monitoring. But for those patients with a more mild or moderate presentation that is uncomplicated, perhaps you can consider treatment outside of the critical care setting using a subcutaneous insulin approach. So here are some studies that have taken a look at that. So you'll see here, looking at either Q1 hour or Q2 hour subcutaneous insulin for treatment of DKA in comparison to this more traditional IV insulin approach. And what you'll notice here is that the duration, time to resolution, hypoglycemia, and insulin was actually pretty similar. So for this reason, many institutions may adopt a practice and protocol using subcutaneous insulin in the non-critical ill setting. And this is just an example of our guideline here. We do utilize this in combination with early basal insulin therapy, which is also another sort of newer movement in treatment of DKA. So giving that long-acting insulin actually within 12 hours of the insulin infusion to prevent a gap in basal insulin coverage. And some studies have shown this to be advantageous in terms of preventing a gap, decreasing rebound hyperglycemia, and also expediting the treatment. So you have your treatment. We know we're doing insulin, we're doing fluids, we're doing electrolytes. How do you know when it's resolved, when to transition, and how? So we're all taught when the anion gap is closed, when the bicarb comes back up to your baseline. It's important to note here that the time and transition here is actually really critical, right? But for whatever strategy, if you're using IV insulin, you have to make sure that you're allowing, think back to my pharmacokinetic table earlier, you're allowing the subcutaneous insulin to be therapeutically effective. So you have to make sure that you, let's say, overlap the insulin infusion for 2 hours to make sure the subcutaneous insulin is actually working. Another important thing to think about is at the time of transition, patients often need a higher than weight-based estimate dose of insulin. It's really because with the ketosis, you also see more insulin resistance, and as the metabolic derangements and the ketosis resolved, you're probably going to get closer to your weight-based estimates in the subsequent days. But don't forget about the timing for transition, because timing here can be everything. So what about hyperosmolality? So when we think about patients with HHS, is there anything else? It's still going to be insulin, fluids, and electrolytes, but is there anything else to consider? So there are really no randomized controlled trials with respect to the rate of correction, but most expert opinion is to avoid lowering by more than 3 milliosms per hour. And then when you're thinking about the sodium here, you do have to make sure that you're correcting the sodium for glucose. Importantly, correction of HHS is actually leads to a very predictable improvement in mental status. So if you don't see this, don't forget to look for something else: toxic alcohol ingestion, other infectious etiology, because sometimes the presentations, especially with glucose, can look similar. So other things to think about in terms of management for hyperglycemic crisis, making sure that the metabolic derangements truly have resolved. We talked already about the timing and overlap for transition, making sure your subcutaneous insulin program is taking into account their nutritional intake for someone who's insulin deficient who's eating. Don't forget to give them nutritional insulin. And then last and certainly not least, don't forget about the underlying etiology. So lots of strategies to think about how we do this, right? What do we know works? There's lots of evidence for standardized order sets, IV insulin protocols, many of which you can integrate as part of the electronic medical record. But even though we've fixed what's happening in the hospital, it's equally important to think about these patients for transition of care. So this is, again, one approach to think about how might we safely transition patients home from the hospital and using their most recent A1C to help govern your next step. So for someone who's coming in with an A1C over 10, who's taking all of their prescribed medications, maybe this is the time where you're going to escalate and think about adding insulin. For those patients who you are adding a new treatment, especially if it's insulin, making sure they have all of their diabetes survival skills, insulin teaching, appropriate transition of care, and clear communication with the outpatient team is going to be really important. I always get a question here about, which insulins are best or covered. The truth is, it is going to depend on the patient's insurance, but it is really helpful to actually have a sense of that before hospital discharge, just to make sure that when the patient is discharged, they can actually get the medications that you're prescribing. So we have so many medications. We're very fortunate that we have many different therapeutic targets, especially for type 2 diabetes now at the level of the pancreas, the level of the adipose, the muscle, the gut, the brain, the liver, the kidney. There's a lot to keep track of when you think about what medicines and do I have to make any sort of adjustments. So just a few moments on what are the other things that we should think about? When should we think about non-insulin agents? Do we have to have any dose adjustments before we go home? There are newer insulins. Is there anything that we need to take into consideration? And then we'll touch on diabetes technology. So we spoke a little bit about metformin earlier. And I think that for much of what we're doing is that we're not starting metformin on admission, but over the years, you may see a movement in a stable patient who's preparing for discharge, no plans for imaging with contrast, to restart metformin in the 24 hours, 48 hours before hospital discharge. When you're thinking about metformin, it is important to pay attention to the renal function. So for any of you, the greatest risk for metformin-associated lactic acidosis is really going to be with GFRs less than 30. But for someone who's coming in on metformin, you want to make sure that you review the GFR prior to hospital discharge, just to make sure that that dose is still appropriate for the patient. What about some of the incretin-based therapies? So I alluded to this earlier about DPP-4 inhibitors. So there have been a number of studies in recent years looking at the traditional insulin approach with basal bolus and then basal plus a DPP-4 inhibitor. And what I will say, what we've learned from the literature is that DPP-4 inhibitors may be quite effective for patients with mild to moderate hyperglycemia. And much of the work has really focused on, again, lowering the risk of hypoglycemia, minimizing injection burden, and can be quite useful for some patient populations. For this reason, this was actually included in the most recent guideline update to think about patients who might benefit from this adjunct during hospitalization. So much of the literature supports use in patients with type 2 diabetes with a more mild form, let's say A1C less than 7.5 on oral agents or on this less than total daily dose of 0.6 units per kilo. And there's been ongoing interest to also use these agents in patients with stress hyperglycemia, particularly because it conveys a low risk of hypoglycemia. For patients who are on DPP-4 inhibitors prior to admission, same thing. Don't forget to review the renal function because sitagliptin and saxagliptin do require renal dose adjustment. Linagliptin does not, but you just want to make sure that you're sending the patient out with the appropriate dose after hospitalization. We spoke a bit about SGLT2 inhibitors already, and I think the best advice I have for SGLT2 inhibitors, particularly for patients who may not be eating and drinking reliably, that's going to be an important consideration about time to restart these agents because you want to make sure that they're sort of back to their baseline eating and drinking appropriately as they're taking these agents. for this purpose, SGLT2 inhibitors, there's guidance prior to planned procedures. We talked a little bit already how it's often discontinued on admission and again restarted as part of transition of care and carefully selected patients. But the data from a glucose perspective, from an inpatient glycemic control, that sort of investigation is ongoing. What about some of the concentrated insulins? Anything to know about? So all of the insulins that I shared earlier were U100. What does that mean? Insulin is dosed in by volume, right? Units per volume. So in this much volume, there's 1 unit of insulin. The thing to know about concentrated insulins, in this very same volume, we have packed in 2, 3, and 5 units respectively. So for U200 and U300, those are in insulin pens. The pen will do the math for you. But I do just want to quickly highlight U500 because U500 regular insulin can be delivered in several different modalities. It can be given by vial and syringe. It can also be given by an insulin pen. So that's important to note for when patients are coming in on U500 or being discharged on U500 because it's really important to know how they're getting it to be able to understand what dose they're taking. Because inevitably, every time you ask a patient and they say, oh yeah, I take 25, the question is, do they take 25 units or do they drop to the 25 mark? So it's really important to understand how they are getting it. And then equally important, how they're going to be getting it after discharge so you can appropriately give recommendations for dosing. And then finally, diabetes technology, which is so exciting. There has been an explosion of the available technology over the last few decades. And I think many have seen increased popularity with continuous glucose monitoring, insulin pump therapy, and really all forms of diabetes. So what should we know as this relates to the inpatient setting? So there are many different sensors that are out there. This is just one particular study to pay attention to with respect to some known interfering substances. Big picture, you have to make sure that if patients are undergoing imaging, they will need to remove the CGM for MRIs. There's really so many studies with ongoing interest to see the role of CGM and accuracy in the setting of surgery, impressors, periods of rapid glucose fluctuations, impact of medications. And for this reason, CGM is not officially approved in the inpatient setting at this time, but most, and we'll say some of the early studies have been quite promising. Some of these studies are smaller, but what I will share quickly when you think about the data, so much of the CGM accuracy data is using this Clark's error grid, zone A being 20% of sort of the gold standard reference range glucose. So zone A and B are really what we're looking for, and I'll be brief on this. But what you'll see from some of the earliest studies for CGM in the hospital, what we've learned is that there can be a higher detection of hypoglycemia, particularly in the overnight period for which patients traditionally may not have glucose monitoring. So it's been very helpful in a number of studies looking at both improvement in hypoglycemia detection and some of the newer studies looking actually at accuracy. So when you're thinking about patients who are hospitalized, point of care testing, CGM testing, there are some important differences. First, to remember that finger stick is going to be capillary glucose, CGM is going to be interstitial glucose. It certainly can have advantages when we think about some patients, particularly for those who are on very frequent glucose monitoring, those who have significant hypoglycemic unawareness, particularly because some of the devices do have alarms for hypoglycemia. So this can be a really useful tool. And where are we now, right? Amidst the COVID pandemic, many institutions have allowed CGM. It was for emergency authorization during the pandemic. And I think many institutions have adopted guidelines to say how we might utilize continued personal use of these devices. And I will say the most recent sort of guidance on this is really that patients may continue to use their own doses if you have their own devices, if you have a glucose management team and institution that's available for consultation. All of the efficacy studies are still in progress, but we are awaiting formal approval in the inpatient environment. Our own personal approach at our hospital is that patients can continue to use their CGM for directional guidance, but all treatment decisions still must be based on the hospital calibrated glucometer, with clear sort of documentation and references for any potential interferences, as well as when to remove the devices. And then finally, some of the insulin pump therapy, especially some of the newer ones, actually do have the ability to integrate with CGM. Think about this as automated insulin delivery. So what this means is that a patient is wearing the continuous glucose monitor. CGM is going to Bluetooth to the insulin pump. For some of the pumps that have compatibility and algorithms to take that data and automatically increase or decrease insulin delivery based on the glucose trend. So these are also very popular systems. Some of the earlier data looking at hospitalized patients has also been quite promising, increasing the time in range without risk of hyperglycemia, even in comparing some patients with quite challenging sort of glucose patterns and clinical scenarios amidst dialysis, amidst different nutritional programs. So I think we're still learning from some of these studies, but what we have seen so far has actually been quite promising. But because CGM is not officially approved in the hospital, I think when CGM and AID systems with more and more data, we'll start to see a bit more on this for more formal guidance. What is the guidance right now that you can and should continue patients' own devices in individuals who are capable to self-manage, as particularly in institutions when you do have diabetes experts available for consultation. The inpatient studies are ongoing, but I think many of you probably see these devices more and more in the hospital these days. Just to share our approach, our insulin pump patients are seen by our inpatient diabetes team at our hospital. And again, we are still doing point of care testing to confirm while patients are using the continuous glucose monitors, but we do allow patients to utilize their automated insulin delivery if able to self-manage, and the CGM is congruent with our glucose testing. So finally, I've covered a lot. We have come a long way over the last few decades for glucose management. And what do I think? I think it's only going to get more exciting. Do I think we're going to see more oral agents, more computerized algorithms, more CGM, closed loop system, change in targets? I actually think the answer is going to be yes to all of these questions. So stay tuned, much more to come. And then finally, when I take us back to our patient from the beginning, the 55-year-old gentleman with hypertension and hyperlipidemia who's coming in with an NSTEMI with no prior history of glucose intolerance, but was found to have a glucose of 225 on admission and 200 the subsequent day. On to my question, is this important? Is there a role for monitoring and treatment? I hope after our time together, you will answer yes to all of these questions. And thank you so much for your time. And I think we do have some time for questions.
Yes,
Great.
Thank you so much, Dr. Palermo. That was so comprehensive, and you, of course, already addressed many of the audience's questions. The most upvoted question was about diabetic diets. You mentioned that the rationale for the carb restriction is for safety of insulin dosing, but some of the questions were about whether or not we should liberalize the diet so that we can more closely mirror the insulin that they need at discharge. So if you could comment on that.
Yeah, it's a great question, and thank you for that question. I think that inpatient is always an opportunity to best sort of figure out how we can partner with our patient and improve glycemic control. And if that can be done, such a way to optimize their outpatient program, absolutely. I think the challenge is just knowing your patient and individualizing it. So if the diet, both in carbohydrate content and macronutrient content, is comparable to home, you can certainly liberalize it. I think the challenge is, again, when you're thinking about giving doses in the hospital for patients who are eating differently between different meals. And the challenge is really all about combating hyperglycemia, but the limiting factor is always hypoglycemia. So if you can do that in the right patient, you can, I absolutely advocate to use the inpatient time as an opportunity to really fine tune outpatient. It's just about knowing your patient and what might be most appropriate.
Yeah, that makes sense. The next question reflects a lot of the enthusiasm around the SGLT2 inhibitors. And you mentioned that for diabetes specifically, we should hold that in the hospital. audience members were wondering that for patients on those medications for heart failure, are they at risk for euglycemic decay as well when NPO?
Yeah, it's a great question. Comes up all the time. I think I had a few questions even this morning about this from the hospital. So euglycemic decay, I'll preface to say it is rare. I think it's really important that everyone is vigilant about it, so we make sure that you don't miss it, because you're never going to have that high glucose sort of as your threshold. But think about who's most at risk. It's going to be insulin deficient patients who are critically ill. So for patients who are insulin deficient and critically ill with a metabolic acidosis, I think you can't discount the potential for it. But for patients who are receiving this as part of treatment for goal-directed medical therapy, for heart failure, who don't have diabetes, the risk for euglycemic decay is not going to be the same as someone with diabetes. I think for the not say overly conservative, I think it's always good to think about, but I think you have to kind of take it back to your patient population to say, is this a patient who could be at risk? And if you do see metabolic derangements in someone on these agents, absolutely should be part of your differential. But I think recognizing those who would be at greatest risk is going to be important.
Great. And I think we have time for one more. Folks were wondering if you could, is there any strategy for discharging a patient, let's say on a prednisone taper, and then recommendations for how they should adjust their insulin concurrently?
It's a great question. I think something that comes up for so many of us all the time. The question, the first one is always, do I have to send this patient on insulin? Or can I think about something else? So I'll sort of answer it in two parts very briefly. I think the first question is going to be, what's the length of the taper and the duration and the duration and degree of hyperglycemia, right? So if it's a very quick taper in someone who is insulin naive and the glucose is 200, that may not be someone that I'm going to discharge on insulin for, because of the risk for potential for hypoglycemia. I think to the question about how do you taper it, often it depends on the taper. So if you do have sort of ratios that work, you certainly can proportionally decrease it. Is it often, is it 20%? I think it really depends on what the steroid taper is. If the steroids, and I'm just going to make it up for sort of easier numbers, but if you have 60 of pred and you're giving NPH 6, when they go to 50, maybe NPH 5 is appropriate. I'm using easy numbers now, but then 40, 30, 20, you may want to taper it that way. But the truth is, it really does depend on your patient, the degree and extent of hyperglycemia, and your planned taper.
That makes sense. Well, thank you so much again, Dr. Palermo. That was a really helpful lecture and one of my favorites. So